Okay. I'm going to start really soon, but thank you everyone to this to May's masterclass. Again, please remember to use the hashtag ePrescribing Masterclass. Okay, just give it 30 more seconds and we'll get started. Okay, all right, I think we're going to get started. So I'm Steph Garty. I'm one of the clinical fellows working within the Transformation Directorate, and welcome everyone to this month's May's Masterclass. We're going to have two different presentations today, so feel free to put any questions or any queries within the chat box, and we aim to ask them during the session. Okay, I'm going to introduce our first speakers. So we're having Neil Kirby and Hilary Beliffa from Salford Northern Care Alliance NHS Foundation Trust, and he'll come to speak to us about discharge summaries and sending them out to community pharmacies. So I'll pass over to Neil. Are you coming to Stratford on Tuesday? Neil?
Okay, thank you. Thank you very much for the invite today. And we're going to talk to you about how we send patient discharge summary back to community pharmacies via our hospital EPR. My name's Neil Kirby. My partner in crime is Hilary Beliffa alongside me. Our email addresses are on the first slide here, so feel free to email us afterwards if you feel you need any more information. Next slide, please. So a brief bit of background, the Salford Royal and Pennine Trusts merged recently to create what's now called the Northern Care Alliance, but the work we are describing today applies only to the Salford Royal sites. The Salford Royal site, which is a teaching hospital with approximately 780 beds. We use the Allscripts Sunrise Clinical Manager EPR. It was implemented in August 2000. It's the primary source of patients' records across the whole of the trust, and that includes the emergency department, critical care and intermediate care, as well as the general hospital, of course. We introduced inpatient prescribing in 2011. The e-referrals project, which, sorry, just go back again, please. The e-referrals project, which this project was initially entitled, went live in February 2019. Initially, it was for community pharmacies in Salford only, of which we have about 70, but that was extended at the end of last year to Greater Manchester pharmacies, and we have about 650. So next slide. Brief outline is I'm going to summarise some key elements of the project, describe how we create an initial referral to our community pharmacies, how then the discharge summary is sent, and importantly, I'm focusing on the practicalities, and we're not going to talk about any technicalities. It's important to say that our technical team have been very supportive and still help us with errors and such like, but we're not going into any detail of the interfacing or anything like that. Hilary will then talk about outcomes, our successes, our challenges, and our future plans. Next slide. So some key elements of the project. First of all, the project in some respects started way back in probably about 2016-17 under the sort of heading of Axe the Facts. We had approximately, on average, 8 faxes a day that we sent out to community pharmacies for patients who were on compliance aids, but that's an average, and the numbers actually varied quite dramatically. We could have more than 20 some days. So there's a significant burden on the dispensary staff on the fax machine and the pharmacists to ensure that the community pharmacies were appropriately contacted. We wanted to ensure that a full copy of the patient's discharge summary was sent to their nominated community pharmacy, and we would do that to the farm outcomes application. Now, I'm not certain if everybody knows what farm outcomes is. Essentially, it's an application used by community pharmacies nationally to manage, and in some cases claim payment for enhanced services such as vaccination programs and the discharge medicine service. we wanted to ensure that our pharmacy staff were interacting with our EPR only. We didn't want them to have a log on to a third-party system. We didn't want to have to manage a third-party system. We wanted them to use the EPR product, Sunrise Clinical Manager, with which they were already familiar. And it's worth saying that we quickly realized after go live that actually our concept and workflow that we had developed would actually support the national requirements around TCAM, what was then called TCAM, now Discharge Medicine Service. Next slide, please. So in order for the process to work, we need to create an initial referral to the community pharmacy. This is normally done by the ward pharmacy team, pharmacists or technicians, and is normally done as part of the medicines reconciliation process. So you can see here a section of a medicines reconciliation document, and you can see highlighted there the yellow button, which is community pharmacy referral. So if we click on that, I'll go to the next slide. So on clicking on the button, the referral order form opens. You can see there's a number of fields there. First of all, the user must indicate the reason for referral, which in nearly all cases is a compliance aid. They must also enter the pharmacy ODS code. So this is the ODS code is the unique identifier for all pharmacies, in fact, all healthcare establishments across the nation. And the referral form, as you can see, pulls across the patient's address and postcode. So if you click on the next slide, so when the user selects community pharmacy search, it pulls a map on which we, and I say we, it's Hillary in fact, has transposed all of the names, locations and addresses of all the pharmacies in Greater Manchester. So what the user would do is select the relevant pharmacy, in this case Sykes Pharmacy, so we'll click on that. So next slide. And that pulls across the ODS code. As you can see, it's been transplanted in the box there. It pulls across the name and address of the pharmacy with telephone number, etc. We also ask that the patients give consent to share their discharge summary with the community pharmacy, and that's the little tick box at the bottom. So on saving that document, next slide please. At the bottom of the page there, you can see that the community pharmacy referral is saved within the patient's inpatient medicines list within the EPR system. Next slide. And at the same time, that referral is sent out to Farm Outcomes. So for those of you who haven't seen Farm Outcomes, this is what one page of it looks like. And you can see the highlighted section at the bottom there, which is the referral that we have sent to them. And this serves two purposes. One, it needs to be there for the subsequent sending of the discharge summary, which we'll describe in a second, but also that community pharmacy now knows that that patient is admitted to hospital, and so they would be aware that perhaps a compliance aid that they were due to prepare and send out is no longer required. Next slide. So at the end of the patient's hospital stay, we need to prepare a discharge summary, and this is made up of two parts. So as actual text document, what we did to the patient, what follow-up they require, and that's in a discharge summary document, which is highlighted there. And then on the next slide, we enter the patient's discharge medications, excuse me. So the patient's discharge medications, they're indicated with the little thumbs up sign. Next slide, please. So at the point at which the patient is discharged, the discharge summary is then sent out, and that's an automated process. So it requires no further input from the pharmacy staff, okay? And in effect, it replicates the existing process we have for sending our discharge summaries to GPs, in that the trigger to send that out is the discharge notification through our PAS system. In order for that discharge summary to be sent, the patient must have an active inpatient referral, which we've already seen, and they must have an active discharge summary document, which we saw earlier. Next slide. And then at 2 hours after discharge, and I'm sorry, I don't know why 2 hours was chosen, but at 2 hours after discharge, the discharge summary is then sent out to Farm Outcomes. You can see it highlighted here within Farm Outcomes. At a glance, it looks very similar to the initial referral, but it is actually a different entry. And if I were to click on that entry, Next slide, please. I will be able to drill down to the detail of that discharge referral, and if I wish to, open up a PDF of that discharge summary, exactly as it was prepared in the EPR system, with the patient's details and the discharge letter and the discharge medication. It's also worth saying that there are 2 other PDFs on that same page, and that is because we send updates at 72 hours and a week if there have been any modifications to the discharge. In an ideal world, you would hope that wouldn't happen, but we do have modifications. So we can send a modification at 72 hours and then again at a week. So next slide. And this is Hilary now.
Hello. So I'm going to run through the outcomes, some of our successes and challenges, and our plans for the future. So outcomes-wise, with Go Live being in February 2019, we now have usage data spanning 3 years. And we've also benefited from academic evaluation from the Greater Manchester Patient Safety Translational Research Centre. They've helped us to understand and improve the system across that time. So some important time points to think about in our outcomes data: the financial incentivization with the DMS service being commissioned from the 15th of February 2021, and also locally the scale up of our project from phase 1, which was just the community pharmacies in Salford CCG, to all pharmacies within the CCGs of Greater Manchester, and that happened in September 2021. Remembering from what Neil was saying that our system also includes an admission notification that goes through farm outcomes, the following data that I'm going to present just focuses on the discharge referrals, as this is the nationally commissioned service. Next slide, please. So just some headline data about the total referrals, discharge referrals that we sent each year, looking February to February, and the number of those that have been completed on the community pharmacy end. This is consistent and repeated high numbers of referrals since the project began, which we attribute to our automation and the ease of use for our hospital pharmacy team. The total number of referrals hasn't been impacted by the scale up. It's been reasonably static, and the reductions that we've seen in year 2 there are likely due to changes in bed occupancy and the type of patients that were admitted to the organisation during the height of the pandemic. The vast majority of our referrals are still sent for patients using monitored dosage systems. So the data in year 3 could represent nearly £76,000 worth of NHS England money if each of those was turned into a successful discharge medicine service at £35 a referral. However, it's important to note that the majority of these are not completed within the correct time frame to receive that money, and even those that show as completed in farm outcomes, which is where I get this data from, doesn't mean that they've been claimed for through the NHS BSA Manage Your Service app that the community pharmacies need to use to claim that service. A note on the consistent greater than 70% completion, including before the financial incentive of DMS was introduced, was a surprise, and contrasts with the 31% completion found in the Newcastle area study that was published before we went live with this. That used farm outcomes to send the discharge information to patients' usual pharmacies as well. Completion for our purposes can be achieved without a full review with the patient present, but it does include an acknowledgement that the information that has been received from the hospital discharge matches the next prescriptions available from the GP. So a medicines reconciliation has been undertaken. Next slide, please. So just a quick note on the sequin that's come out this year. So CCG7, timely communication of changes to medicines to community pharmacists via the discharge medicine service, requires that 1.5% of acute trust inpatients having changes to medicines communicated with their patient's chosen pharmacy within 48 hours following discharge, in line with NICE Guideline 5 via secure electronic message. So some of our local statistics here for financial year 2020 to 2021, we had 68,815 admissions to Salford Royal NHS Foundation Trust, which it was at that time. During that time, we sent 2,349 discharge referrals, so this was pre-DMS, sent through farm outcomes, and that gave us a 3.4% referral rate. And this is, again, just with that focus on monitored dosage systems. The automation of our system means that we achieve the sequence target. The discharge summaries are sent 2 hours after PAS-off, as Neil explained, and therefore achieve that within 48 hours target. And due to our pre-existing success with this project, the sequence hasn't been selected by our CCG. Next slide, please. So due to time constraints, I'm just going to focus on the successes that I've put in bold here. So our main motivation when designing the service was to save frontline time, to remove the need for unnecessary phone calls, and to allow notification of admission and discharge to happen at the point of admissions reconciliation whenever that occurred. We have staff working until 8, 9 o'clock at night across a 7-day service. This system allowed that to happen and dramatically reduced the outstanding medicines reconciliation tasks of contacting community pharmacies for this type of communication during office hours, and the mountain of faxes that needed to be sent on a Monday morning for patients who'd been discharged over the weekend. Once the system began to embed, which only took a few weeks, the engaged community pharmacies became satisfied that they would automatically get the discharge summary when the patient left any of Salford Care Organisation sites that use Summarised Clinical Manager. So this includes our intermediate care units. The reliability from this automation proved really popular and saved time across the interface, so not just within the hospital, as community pharmacy colleagues knew when their patients had been discharged and that they needed to be asking and what they needed to be asking of GPs where discrepancies were found with next scripts. We've also had anecdotal reports of time and waste, medicines waste saved due to GP pharmacists being able to see which of their blister pack patients are in hospital, and the reliability of the system being automated, meaning that community pharmacies were confident to place their patient on the in-hospital shelf until they get their discharge notification, because they know that they will get their discharge notification at the point of discharge. During the first 6 months of service, Mark Jeffries from the Greater Manchester Patient Safety Translational Research Centre undertook a qualitative evaluation of the service, and this is available on PLOS One. I'll go through that in a second. And we're also awaiting publication of a quantitative evaluation on the harm and medicines reconciliation discrepancies identified before and after our service implementation of going live with this. Next slide, please. I'm not going to read this out. These are some of the quotes that were found in that qualitative evaluation. So this is just really highlighting that that the success statements that I put in the previous slide are opinions that were held by the health professionals interviewed for this study. Next slide, please. So we knew that training and communication, both within the hospital teams, between the hospital and community pharmacy teams, and inside the community pharmacy teams would be a challenge. We put on funded events badged as for continuing professional development with the support of the Academic Health Science Network and the local pharmaceutical committee. Also attended to show community teams how they'd be able to benefit from using the system, remembering this was pre-DMS and the financial incentivization. These were really poorly attended. I spent a lot of time sending letters, emails, individual telephone calls to try and get the original 67 stores to send representatives to understand what our system was going to be offering, and also to offer support after the project went live. But the engagement was still really patchy. In the farm outcome statistics, I can also see where stores have changed management or got to the end of a financial quarter and had a tidy up of their farm outcomes account, and they bulk reject or complete these referrals off, so showing that they're not actually doing them in a timely manner. With the system scale up to Greater Manchester, there was no capacity to provide training for all 700 community pharmacies in Greater Manchester. A message was sent to all the farm outcomes accounts that would be included including a frequently asked questions and hints and tips document that had been developed, and how to contact me if there were any systems queries. I have not had any contact. As this system was a replacement for a fax, and we didn't previously know what the community pharmacies actually did with the information we sent them, there were no systems or funded time in place for managing communications after the point of discharge. For example, where referrals were rejected or if there were queries, and this became a really large unexpected time sink. We continue to spend up to 2 hours a week on maintenance, which includes managing rejections, ad hoc training of community pharmacy teams where there have been systems misunderstandings, maintaining the map and maintaining an accurate list of active pharmacies within Greater Manchester. Because we offer the admission notification as well as the discharge referrals, the admission counts as a locally commissioned service within Pharm Outcomes, and therefore pharmacies have to be activated or accredited to receive these notifications. And there seems to be around 10 changes a month with pharmacies closing or changing hands where the ODS codes update, and this requires a change in our database. To give scale to the rejections maintenance, looking at rejected discharge referrals alone, there 5.4% of the 863 discharge referrals sent in Q4 of 21-22 were rejected, and 4% of those have been documented as correctly rejected, so not due to a training issue. Reasons might be the patient's been readmitted to hospital, their care setting has changed and that pharmacy no longer needs that information, or the patient has passed away. Some of them may be due to incorrect pharmacy having been selected on the hospital side. A system which removes the possibility of operator selection error by finding the patient's current EPS nominated pharmacy and also providing a self-maintaining database would be the solution to this. Next slide, please. So service future, the original mission statement for this service was a three-way communication between pharmacy professionals to ensure safe and optimised pharmaceutical care for patients transitioning between care boundaries. We're still not at the point where the health professionals are able to directly communicate with each other, but information is now viewable by our GP practice teams as well as the community pharmacies. We still focus on referrals for patients who use monitored dosage systems and also for patients who are in substance misuse programs. But with the DMS framework, there are far more varied reasons why we might refer, and our system is set up to support this or support referral for any reason. Locally, we have work planned to improve our communication around medicines for care home residents. And we've also been asked by some trusts regionally who take our patients for step down and rehabilitation to explore methods of information transfer specific to the pharmaceutical needs of a patient. Currently, our integrated map and associated accreditations for the admission service only covers Greater Manchester. In order to expand this nationally using our automated system, so we can do it as one-off manual ones, but to do it with the automated system, we would need to find much more dedicated administrative time to keep the database and the map maintained if we were looking at this nationally. Next slide, please. Any questions?
That's great. Thank you, Hilary. Thank you, Neil, for this. So there was lots of questions in the chat, so I'm going to go through them and ask them. So one of the questions is, do your patients consent for this? And as Michael says, for their Pharm Outcomes DMS, they just send a list of TTO medications with consent, but not the whole summary like you had said that you do.
Yeah, so there was a lot of discussion around this at the start of service and at service design. We were very keen for our community pharmacists to be treated as clinical professionals and have access to the full information. The list of medicines is obviously very useful for a drug history, but without the clinical information of the admission, so why has that patient's ACE inhibitor been suspended? They have an AKI, it may be restarting. Without that information, we were thinking that we wouldn't be giving them as much information as they could need. Obviously, it is a large amount of information about that individual patient, and that is why we do inform the patients that we're going to be sending this information about them, and they have the opportunity to decline that. However, from a information governance perspective, and this was obviously discussed before this went anywhere near live, this isn't a procedure, and it's not something that we need explicit consent for. This is information sharing in the best interests of the patient to prevent them from getting the incorrect medicines afterwards. So we include that statement, and we inform the patient, and we do tell them that the pharmacy will be getting the same information as their GP receives and the same information that they receive. So they also get the exact same copy of their discharge summary.
Yeah, that's great. And have you had much pushback from patients when you've told them explicitly?
And the qualitative study is quite an interesting read if anyone's got the time. It did also include patients, and the themes that came out from the patients were surprised that their pharmacies didn't know anything about them, and that they'd all experienced previously issues with the communication not happening with their pharmacy, and were really pleased that something was going to change about that. I think it would be interesting, because that was done in the first 6 months of service. I think it would be really interesting to revisit that and see whether patients have had more positive experiences now across that 3 years. But I haven't had a patient say no, and I've not had anyone report one saying no.
No, that's great. I think we're probably not going to get through all the questions, and I may ask at the end, will you be able to, I'll send you the questions and we can send it out to everyone at the end. Just a couple more. Do you have any issues with community pharmacies that are working in a hub and spoke model when it comes to compliance aids? Have you had any issues?
So again, at the start of service, these were things that came as a little bit of a surprise to us, and we have one small chain that operates in Salford who have hub and spoke, and we had discussions with their teams. So it's all about, I guess, engagement and communication with the community pharmacies about where they wanted that information to be sent. So the response that we got back from all of the community pharmacies that were operating in that way was that the base store does retain clinical responsibility. So this information should go to base store. It was just finding out who wanted that information. Obviously the majority of the hub and spoke ones, the clinical responsibility is maintained by the home store, and then the prescriptions get sent through to them. So the home store wanted the discharges.
Okay. Yeah, that makes sense. So another question is about, I think it basically is saying that does your medicines automatically populate from your discharge summary from the TTO, from the EPMA system? I'm assuming yes. Yeah.
Yeah, so it's all fully automated.
Yeah. And the other question is about, does everyone use Allscripts? Does this work just for only Allscripts systems, or do you have other systems bar Allscripts who also use this?
So for electronic prescribing, I presume that's the question. So all our prescribing, all our electronic prescribing is done on Sunrise Clinical Manager, and that includes day cases, chemotherapy, ED, intermediate care. So we've tried very hard to focus on having one single system for all our prescribing.
Oh, no, that's great. I think I'm going to say one more question is, do you get follow-up on any results of anything regarding medicines errors that have been collated from your community pharmacies once the discharge summary has gone through?
So the systems that we have in place for that, because the majority of the hospital pharmacy team do not have access to farm outcomes, they don't see any queries that come back on there. We have, as part of our training, we explain that if there are clinical questions regarding the content, they need to call inpatient pharmacy and discuss that with a pharmacist there, because unless they reject the referral into farm outcomes, we won't be able to see any of their communication in there. So if there are queries that need following up with the hospital team, the community pharmacies are told that they have to contact us, and the contact details are listed on the referral, so they know who to contact. And it also says which person entered the referral into our computer system, so they have a name of a pharmacist to ask for as well. The otherwise follow-up, our GP practice pharmacist team in Salford, which are Salford Royal employees as well, so we are very integrated with them, also have access to the information going through the system. So whilst they can see the discharge summary as it has appeared in the GP system, they can also have an overview of the patients who have had referrals, and they also get notification where the community pharmacy has identified discrepancy. So if there are any issues raised on pharma outcomes, our GP practice team have that patient highlighted to them as someone that they need to have a look at on the GP end. But again, the community pharmacies are still encouraged to contact the GP directly. What has been really useful, and what is mentioned again in that qualitative evaluation, was that now the community pharmacies have the exact same information as what the GP has. The conversations are much more clinical than to do with logistics.
Yeah, no, that's great. And it's always more encouraging for us to work more clinically, and it should be a thing, like the patients have said, they're surprised when information is not shared, that more information of patients' care isn't shared more widely. Okay, thank you for your presentation, and lots of people said it's fantastic work and should share this more with wider networks. I'm going to go on to our next presentation. Okay, so I'm going to introduce Niall Paul and David Hancock from InterSystems, who are going to present their learning hackathon idea, the winning hackathon idea from a hackathon that we had recently with INTEROPen, looking at dose syntax and GP Connect and how we can move forward with our shared medication record. So I'll hand over to David and Niall.
Okay, thank you very much indeed, everybody. I'm David Hancock. Not only do I work at InterSystems, I am also the vendor co-chair of a group called INTEROPen. And INTEROPen is a group made up of the service, suppliers, and standards bodies trying to drive the adoption of open interoperability standards to support the exchange of information between different clinical systems. And one of the things which we've done in order to support that is actually work on things we call hackathons. And a hackathon is where we bring system suppliers together to be able to use particularly new and emerging interoperability standards to actually see if they can successfully exchange information in a safe and meaningful way to be able to support clinical workflow. And the interoperable medicines team in what was NHSX and now NHSEI has been incredibly supportive of this work and has done a lot of work with INTEROPen on these hackathons. And what we would like to talk about today is one of these most recent medicines hackathon we did around GP Connect and structured dose syntax. Before that, though, I'll give a little bit more background on INTEROPen. So next slide, please. So INTEROPen is an open collaboration of individuals, it's industry, it's standards organizations, it's healthcare providers, and as I say, trying to drive the adoption of open interoperability standards. Tech UK, who I'm also a representative of, which is a representative body of the tech industry, particularly as a group to government, and InterSystems were founding members. We have a board with co-chairs. We meet about every 2 months. It's free to join. But the thing is that's really important is that commercial interests are put to one side in the group's activities. So we basically leave our business cards at the door, certainly as suppliers when we come and work at INTEROPen, because what we're trying to do is collaborate and to drive interoperability and make it work more effectively. And I've got a little image there of a stool, like a three-legged stool, because that represents the fact there are three legs to what we do. It's about working with the service, it's about working with suppliers, and it's working with the centre as well, what is now the NHS EI Transformation Unit. And if any one of those groups is not there, or any one of those legs is not there, the stool will fall over. And we have to have all three working together to be able to successfully collaborate and co-produce the work we need to do on interoperability. Next slide, please. Thank you. And here's just a list of the board members that we have. So I'm at the top right there in my role as an industry co-chair. I've got a service co-chair who is Luke Redman, who is one of the digital transformation directors in NHSE, and also the strategic responsible officer for One London Care Record. And then you can see all the other people that we have. So we have representatives from the PRSB, from social care, from the CIO networks, the CCIO networks, the CNIO networks, as well as social care and what have you. So we have broad representation that again reflects all the different groups we need to successfully land interoperability. Next slide, please. Okay, if you go to the next slide, I think, yeah, this is probably my last slide. Hackathons. The reason why we use these hackathons is that quite often in the past, what we found is that interoperability standards may well have been defined by NHS Digital, and yet they haven't really been considered in terms of just how easy to implement are they? How easy is it for system suppliers to be able to use? So what we want to be able to do is begin to change that and to be able to make it all focused on implementation. And and something else that we need to do in following up on that is not let perfection, be the barrier to some kind of success. Something's got to be good enough. It doesn't have to be perfect. So what we're doing is we're allowing developers to get their hands on interoperability standards and particularly through APIs, and test them for real to make sure they work and understand them. We help the service see how these work so they can work with suppliers on adoption, and help product teams in system suppliers understand actually what it will take to implement them in product, and to help them plan these into their product roadmaps, because we have to be able to give suppliers the chance, the understanding to be able to do this, to make it predictable, so we can do it in a timely way within which the service is going to mandate. Next slide, please. So now I'd like to be able to hand over to my colleague in InterSystems, Niall Paul, talk about the GP Connect hack we did in October 2021.
Good afternoon, everyone. My name is Niall Paul. Thank you, David. I'm a pharmacist by trade, just for a bit of background. So 10 years working in the NHS, and now 10 years working for health informatics IT suppliers like InterSystems. I'm going to go through what we did at the GP Connect hack in October last year. Next slide, thank you. So what were our objectives? What were we trying to do? The scenario we were looking at was that admission transition for the patient. So looking at taking medication history, admission reconciliation. Our particular theme was to build on a previous hack where we'd hacked the GP Connect functionality before and looked at that interface before, but that was before the structured dose syntax had been developed for FHIR. So we wanted to improve on that and see where we could take things. We worked with colleagues from NHS Digital and GP Connect. Pete Salisbury there is the name for the NHS Digital guys we were working with. Gary and Gunders are one of our interface specialists. In terms of benefits, the key benefit we wanted to get was a slicker process for admission reconciliation, really. By having codified dose syntax data, we hoped to be able to improve that workflow for the doctors in hospital clerking those patients. Okay, next slide. So I'm going to show a short video just shortly. There's kind of two parts to this. So the scenario is a clerking doctor taking medication history and preparing a medication plan as part of medicines reconciliation on admission. It's going to be in two parts. There'll be 4 medicines available from the GP Connect interface, as you'll see. In part 1, I'm going to take 2 of those medicines that have got incomplete data because the dose syntax is not available, or we've made it look that way just for purposes of the demonstration. And you'll see that the clinician has to add in extra details manually and the extra time that takes. In part 2, we'll take 2 medications that have got complete details and just show how much smoother that process can be. So if you want to do the next slide, and then, yeah, click play, thank you. Okay, so we're starting here from a list of inpatients. We're going to navigate through to the EPR chart and the medicines reconciliation section. We're doing an admission, so we're just going to start by entering the patient's medication history. We can enter from scratch, but we're going to choose to import. We can import from various sources, but we're going to choose our GP Connect interface. So then we're presented with the data from GP Connect, and we can simply use the little plus button there to add those in to the history that we want to take. So as I said before, we're going to take 2 that don't have complete dosing data. We can indicate the source here. We can indicate a number of sources, as you might expect for doing a drug history. And we'll update those. So now that we've got a medication admission history, we're going to create a plan. So we're deciding what to continue, what to withhold, what to stop. For the purpose of the demonstration, we're just going to continue everything. And when I update that, it's going to take me through to our ordering screen to order those for the inpatient stay. What's indicated in here is you'll see the update button on our order cart isn't available, and that's because the system knows these prescriptions aren't complete. So we have to come in here, check text information that's come through the interface, and essentially as the clerking doctor, I am codifying that text information. So I'm reading that and interpreting, well, what dose does that say? What fields do I need to fill in to meet that need? And that's what we're doing here. So update that, and then we're going to have to do the other one as well. You'll see that little grey bar there is indicating that the prescription's not complete, and it disappeared when we filled it in. Okay, so again, we read the text notes, and we're going to enter the information. So the precise fields that are and aren't available aren't necessarily an accurate depiction of the previous version, but you get the idea here that we're having to key all this information in. We're having to refer to the text notes, and it's taking some time. Okay, having done that, I can complete my basket, update, and those medications will now be on the patient's medication. So we're going to go back into the history, back into import. This time we're going to pick the other 2 medications, which we know have got complete data. And we'll update those. We need to create we just have a quick look at the plan here. We need to update this plan, so we're going to get rid of this plan and create a new one. Okay, so this time we'll continue the other 2 medications. And update to take us through to the order process. So this time we'll see no grey bars. We just need our password, and the update button highlights, and we can move forward. So we can review those prescriptions in the tray there and update them to place the orders. I think just at the end of this video, I think I quickly navigate to the inpatient chart, and we can just see that all those prescriptions have landed on the inpatient chart and are available now. Okay, so next slide. So what did we learn? What did we get out of doing this hack? So I think from a benefits point of view, it was clear that on the second two prescriptions there's a lot of improved speed, and you would hope accuracy, because we're not manually interpreting text and keying it in. It's coming through in a codified form. We don't expect everything to come through perfectly. There's going to be stuff that doesn't fit neatly into the FHIR standard, or isn't, as you'll see in challenges below, isn't currently well coded by the primary care practitioners. But you know, if we could get to 80/20 and be confident about the 80% we can do, then that would be a good place to be in terms of speeding, making that process slicker, faster, and more accurate. It also helps us with the discharge transition. If we've got good admission data, then when we come to discharge the patient, we can give good discharge reconciliation information in terms of stops, starts, and continues, and be able to sort of run that difference engine between what you came in with and what you go home with, which will obviously be really useful for the primary care recipients of that. So in terms of challenges, so some of the things we found during the hack were a lot of the prescriptions in the test data we had didn't have a route of administration, and I guess from my time in community pharmacy, you know, the route of administration wasn't always on there. If it was take one tablet once a day, oral was kind of assumed. So that is going to present a challenge for us. You know, when do we, as a provider, a system provider, say, okay, this is always given orally as far as we know, so let's assume that, or how do we account for unlicensed usage and so on. So missing bits of data present a challenge for us, and whether we can make a leap there or whether it's not safe to make a leap there. So that's going to be a challenge in terms of implementation. Similarly, take once a day, that works in primary care because, you know, perhaps the patient's had a conversation with the GP or with the pharmacist, and they know that simvastatin once a day means take it at night for that, because that's, you know, the right time to take it. But if this is leading to administrations with an EPMA system, once a day is not specific enough. We need a time of day. So some of these more ambiguous descriptions will again cause more issues. Take as directed is another, you know, another classic from sort of community FP10s. So those are some of the challenges that we're going to get when we come to actually implementing this stuff. In terms of stuff still to explore, there's a lot of prescription metadata, things like last issued, last dispensed. What we found when we looked at the data that comes from GP Connect was there wasn't really such a thing as these are the current prescriptions. Certainly there are active and inactive, but what the patient is actually taking, I mean, I suppose to be honest, ultimately you have to ask the patient. You know, there's always that one patient who keeps dutifully getting their repeats because they don't want to upset the GP. So there's only so much we can do with automation, but some of the things like when was it last issued, when was it last dispensed, they can be useful pointers for the clinical pharmacists or other clinicians. And the other issue I would say here is that a lot of historic data on GP systems isn't immediately necessarily going to be up to scratch and have missing bits of data as we've just described. But I think there's an opportunity here for what I would like to call a virtuous circle. If we start delivering quality information out of secondary care systems, because from a secondary care point of view, we don't have a lot of choice. We need routes, we need times of administration, because we're dealing with all that medicines administration side. Perhaps primary care systems can not only interpret that, but actually use it to update their records with the extra fields that they're missing. And that potentially could speed up the process of getting the GP data up to the same standard as secondary care may be issuing. Okay, that's all. Thank you.
That's great. Thank you. Thank you for your presentation, and thank you for explaining to the audience about hackathons and what actually happens in a hackathon. And there's a question I would like to ask about, what do you do now with this, with the work that's done with the hackathon? How are you going to build upon it and use it in real life, or what are the plans? As I know that you're working with just NHS Digital, and it was a collaboration effort. So what's the plans now?
Shall I answer?
No, sorry, I was on mute, so I will. I'll answer that. So what we're looking to do is to be able to work with some of our customers to start to see how we want to be able to implement this. We can't do this obviously without having one of our customers, and it's about customers finding, you know, the time and the priority to be able to prioritize this. There's quite a lot going on in our customers at the moment. You know, goes without saying, elective recovery, things like that. But we are working actively across our customer base to be able to scope this so that we can actually take this and productize it. You know, the important thing is we've done it in a hackathon. We know how to. We've learned from hackathon. You know, if you asked our team, how do you go and build this now to be productized? We go, yep, we know how we do that. And it's really working to get the customer to be customers, or at least one customer to go, yeah, we want to go and do this. It's just getting that prioritized. We are desperately keen to be able to do this, as you could imagine.
Yeah. Okay, that's great. I think there's a question in the chat about how you had mentioned about routes of administration and not being that visible within primary care. Someone suggested that this could be extrapolated from the AMP or AMPP when thinking about the NND. What do you think about that?
Yeah, yes and no. So again, you end up making assumptions. So you assume that a tablet is being taken orally if it's not specifically stated that it's taken orally, but we also know that some of these things, you know, may have unlicensed routes of administration that may be used. So I think, again, this is something to work with our partners, because it's about, you know, what are the risks and managing those. So I think yes, sometimes we'll be able to do that, not always, and that's the bit that needs to be explored, because we don't know what cases are going to arise where, you know, maybe the tablet's been crushed and dissolved, or, you know, other issues that could arise. You know, you've got things like, I suppose not a great primary care example, but vancomycin injection being taken orally rather than, you know, rather than using the capsules. So you've got a number of unlicensed practices which could trip us up.
Yeah, and I think we really need to think about what we're doing in terms of dose and how we are the dosing. So I think maybe GP systems going towards using the dosing standards fully rather than what we're doing now. I think obviously that's going to help in terms of having the interoperability across primary and secondary care as well.
There's certainly a challenge getting everybody's data quality up. For sure.
Yeah. If I could just come back to one other thing which I forgot to say, Stephanie. So one of the things we have done is we've used some of this functionality that we've got here in the hack, where we've actually integrated it into our shared care record solution. So where integrated care systems have developed their shared care records, we have speaking of InterSystems, we have shared care record software. We've been able to integrate just the meds and allergies as structured data, not with dosing, because of dose syntax is something which is extra. But what that means is that rather than within the overall patient summary, You've got the sections in the summary, including medications. It's all in one place. It can all be consolidated and deduplicated in one place. So within that overall patient summary, where you may have their problems listed, their encounters listed, or what have you, you can see their current medication. So we've used this functionality to do that in a shared care record. Obviously, you need far more of this advanced capability when you're clerking and administering patients as part of an EPR.
Yeah, I think that's great. I think I've got one more question, and I think we were talking about the 80-20 rule, and someone has mentioned about what proportion of meds did not correlate sufficiently. But I think, like you said, it's not going for perfection, and I think it's going for what we can and dealing with the 80% that we can get right, and then 20% is what we're working on. Do you agree?
Yeah, I think I think the thing about that, whatever the percentage is, and we don't really know till we get out there and start working with more data. The main thing is that we're the 80% or whatever it turns out to be that we can do, that we're confident about that, and it's clear within the system that we know that we're doing that and that that's accurate. And that for the 20% that we can't do, we're equally confident that we can't do it. And that way we don't present the user with a situation of, well, we think we've got 4 out of 5 of these right, but you'll have to review to work out which ones they are. What we want is, here are 4 out of 4 that we know are right. Here's one that we know we can't do, so we haven't tried. We need to try and get to that position where it's very clear, where we know what we're doing to it's probably not the best phrase, but hopefully you understand what I mean, where we know we've got the data and we can interpret it safely. To be very clear when we know that, and to be very clear when we don't know that we don't lead the user on or force them into a position where they have to check everything because they don't know where the pitfalls are. That's not necessarily helpful.
Thank you. Thank you for answering the questions. I'm sure there's probably more questions. And would you mind answering, and if I send you a list of questions, answering them after the meeting, and we can send them out to our delegates. So I'm going to move on because it's coming to close the session. But thank you now. Thank you, David. Okay, so the next masterclass that we have is on the 8th of June, and that's between 1 and 2 p.m. And there'll be further information that will follow. If anyone has if you're not on the invite list, or you have any ideas for any future topics, or want to volunteer to present, please email Sarah. Also, don't forget to use the hashtag ePrescribing Masterclass, and please join our Medicines Optimization Digital Learning Network on NHS Futures. Also, on that note, I just want to thank everyone who attended our learning event on the 27th of April. We had massive turnout, and within the next week, you'll get details of the recordings if you signed up to attend the learning event. But yeah, I just want to thank all of you for attending for today. And if you have any queries or any questions, please email Sarah on the link that's there. Our next masterclass on 8th of June is going to be focused on antimicrobial stewardship and antimicrobial resistance. So please spread the word to all your networks as well. Looking forward to seeing all of you next month. Thank you. Bye.